Hi, everybody. Thanks for joining us. And today you get to hear from Leslie Van Winkle. She's going to talk about Together is Better, collaborating across disciplines to improve AAC use for children with autism spectrum disorder. But I'm assuming you'd rather hear that from her than me. So I'm going to time over to Leslie to explain it from there. Leslie, appreciate you taking the time. Thanks.
Awesome. Yep. Thank you. Can you hear me okay?
Yeah.
Perfect. Okay. Well, I'm so thrilled to be a part of this conference, and I've been so excited to get to share and have had a chance to watch some of the presentations, but unfortunately have had a full schedule here at work. So unfortunately haven't caught everything that's happened yesterday and prior to today, but I would like to just kind of jump right in. I know we're running a little bit behind, so I want to kind of get to the meat of things here. I listened, Amber, to your session briefly and was able to hear some of the things that you were saying, and I was really glad to do that to kind of piggyback off some of those things. This is my first webinar, so bear with me as we I just want to start by kind of telling you why it is that I want to present on this and why this is such an important thing to me. So I graduated with my master's degree from the University of Iowa in May 2014.
Okay, we're seeing they're seeing audio, or they're hearing the audio, but not the visual. So okay, I'm not sure. I see it. For some reason,
okay.
No one else does.
Okay. I'm not in full screen mode. Do you think I should get out of PowerPoint and try to go back in?
Nope. There we go. Showed up.
It's better?
Yep.
Okay, perfect. Okay. Hopefully they can see that intro and timeline to today. Let me know if not. So as a graduate student, I was a research assistant for our AAC lab at Iowa, but mostly did work on low-tech communication boards for inpatient at University of Iowa hospitals and clinics. And so when I came to my first job or my clinical fellowship here at the Monroe Meyer Institute in Omaha, Nebraska, I had, again, some experience, but just not a lot in the area of AAC for really little kids. And my position here was really supposed to be mostly in the area of autism. And so I had a lot to learn as related to AAC. And so, you know, we have a lot of departments here at the Monroe Meyer Institute. We're a UCED, or University Center of Excellence for Developmental Disabilities. So we have genetics, physical therapy, occupational therapy, speech therapy. We have a Center for Autism Spectrum Disorders that has a pediatric feeding disorders program, a severe behavior program, and an early intervention program, as well as the psychology department, etc. So we have a ton of individuals from different disciplines working under one roof, which is why I've had a chance to get to kind of figure out ways that work and ways that don't work to collaborate with others. And so in January 2015, we had an extern who started with us here who was getting her master's in speech language pathology, but also would be getting her BCBA, or becoming a board certified behavior analyst after she was done as well. And the first thing I said to her was, I know that you do behavior analysis, but I'm not interested in that. I don't do 3-step prompting, like sit down, sit like me, sit like this. So I was certainly not where I am today, if you know what I mean. So over the next 6 months or so, I really got a chance to learn all of the things that I was doing that I had no idea I was doing from a behavior analytics standpoint. So all of this clinical skills that I had as a speech pathologist, our extern could describe to me in behavior analytic terminology. And it really brought me around to this idea that we're all doing very similar things, we're just calling them different, and we kind of have different priorities related to what we're teaching. And it's why it's so important to me to talk about this, because in July of that year, I was able to develop an official collaborative relationship with our early intervention program. And when I started, 0 children used AAC to communicate. And as you know, our young kids with autism, many of them have little to no speech that they use functionally. But by now, we work with 17 children in the early intervention program, and 12 of them have their own devices, speech generating devices, and 14 of them use some type of AAC. So I'm extremely proud of the collaboration that we have established and the education and training we've been able to provide so that we can get our kids functional communication and teach people how to teach them language using a device or some other type of AAC. And again, I started taking classes in applied behavior analysis because this is so important to me and I want to be a good collaborator. And then in just this past year, advocated for hire of a new employee so that we can do this with yet another early intervention clinic through the Monroe Meyer Institute. So that's just a little bit of background. I just wanted you to kind of know that I will be speaking a little bit about behavior analysis and how a lot of our children with autism receive that service and how we can be good collaborators with them for best outcomes. So my plan today is to briefly review autism spectrum disorder. I'm confident that many of you already know what goes into that diagnosis, but I want to talk about associated concerns, who's involved in ASD treatment, what's their model of service delivery, because that difference and how we think about this. What should we teach other disciplines regarding AAC use? How do we get buy-in? So yes, we can teach them, but how do we get them to actually do it? Potential barriers to that, tips from my experience, and then things to consider or action items as you leave this presentation today. Again, thanks so much for joining us. So as you know, a few years ago, the DSM, or the Diagnostic and Statistical Manual of Disorders, changed to the 5th version. And so now to get a diagnosis of autism, children need to meet all of the deficits in social communication, so social emotional reciprocity, nonverbal communicative behaviors, and developing, maintaining, and understanding relationships. And then 2 of the 4 of the second category, restricted and repetitive behaviors. And you can see those there: stereotyped movements, insistence on sameness, highly restricted fixated interests, and then hyper or hyposensitivity or reactivity to sensory input. And again, those must be present in the early development period, and they must have clinically significant impairment. So yes, we all know this, but there's also some other things that I'm also a member of the Autism Diagnostic Clinic team here, which is a multidisciplinary clinic. And sorry, my Slack just gave me a notification. I guess, Scott, it just notified me that someone said something in group, so maybe you could let me know that way too. So there's some things that come up that I see so frequently when I ask questions of parents related to autism that don't necessarily fall into the categories that we use to diagnose autism. So many of our children have food selectivity or gastrointestinal sensitivities, have a lot of difficulties with sleep often, whether that be onset or continued waking in the middle of the night. Hyper or hyposensitivity to pain, that falls into that 4th category if you remember back here under hyper and hypo, reactivity to sensory input, but this is something that parents report frequently, that their kids are either extremely sensitive or not at all sensitive to pain. Fine motor difficulties. As speech pathologists, you know that I don't know how many of you work with autism as a main disorder area, but I think this is certainly something that's co-occurring in many of our children. Auditory discrimination, so the ability to understand whether I'm asking, or to discriminate between whether I'm asking a child, how old are you versus how are you? And I hear children kind of miss that important distinction frequently. And then over or under generalization, so kind of, as you know, in the typically developing child, as language progresses, they might, this happens naturally and we expect it to happen, but we also expect it to go away. So calling all dogs, or anything that has 4 legs and is furry a dog, or calling every dog Sammy, like your family dog. This seems to persist in our kids with autism and certainly has implications for AAC use. And then difficulty with imitation. So this is something that I'm always thinking about and am always mulling over as I think about aided language input and showing children how to use their device and how much their difficulty imitating plays into that and its effectiveness. So there are several disciplines involved in the treatment of ASD, of course, based on kind of what we just described. Fine motor delays, sensory concerns. A lot of our children are receiving occupational therapy. Of course, our communication concerns. A lot of children are receiving speech therapy. But in the past couple of years, with a mandate that insurance provide ABA, high quality ABA services for kids with autism, the amount of children that receive applied behavior analytic services has just skyrocketed, at least here. I don't know about where you are from, but so I have almost all of my children receive some type of ABA service on top of their speech services or their OT services or their school-based services. So how does each contribute? And I think this is this and what is their service delivery model is really something that's important for us to consider as we think about our role, other disciplines' roles, and why it's so important to collaborate. So as you know, occupational therapy, speech therapy, we often operate in an outpatient-based model. So dose, duration, all those things, we're not here to discuss that today, but you know, that might be 2 sessions for 30 minutes each a week. That might be 1 session for an hour each week. I hope some of you are lucky enough to provide even more than that. But often it's not much more than an hour to 2 hours per week, unless you're doing something extremely intensive. And again, I don't think a lot of places provide that. However, the service delivery model for our children with autism who receive ABA is much more intense. So many of our children receive 15 to 40 hours a week of applied behavior analytic intervention, which is, again, 15 to 40 times the amount that I am able to provide to them in a week, just simply based on the differences in service delivery. Because as you know, we are master's trained or master's level clinicians that provide the service directly in speech or in OT or in PT. And I know OT is doctor of OT, but you know what I mean. But in applied behavior analysis, it's more of a pyramidal model. And so they have a master's level trained person who is this case supervisor or what they call BCBA. But the person that provides the service directly is not trained to that level. So they are the BCAB or the, oh my goodness, I just totally blanked. It's the certification board. It's like ASHA for behavior analysts. They have a training now for the people that provide the service directly, and it's called RBT or Registered Behavior Technician. And those individuals are the ones who are providing the service. But the requirements to be an RBT are to do training, and I think it's online based usually. But you have to be, I think, 18 and have graduated high school. So the amount of training that individuals are provided is of course minimal compared to a master's degree in communication. So that's important to keep in mind because I think it changes how we think about who we're training and why, and who would be using the device or the AAC system, and why maybe we might change something on the spot immediately because we see that they can do more, or we're sure that, you know, we undershot or we overshot, but that's not something that we can expect the behavior technician or the person providing the service to be able to do on the spot like that as well. So there's different levels of teaching and training that we're going to want to do for children who are receiving ABA and the people providing that ABA service. So what should we teach other disciplines? And this has been, I don't even think one slide could possibly contend with the things that I've learned over the past few years, but I want to just kind of start here. And again, please feel free to jump in on things that you think I'm missing, or if you've had experience working with behavior analysts and behavior technicians on what do they need to know, or what do we have to share with them. And I think one of the biggest ones is just how to create or identify existing communication opportunities. So as a speech language pathologist, this feels as natural to me as brushing my teeth in the morning, right? I see where a child is motivated, and I know immediately what motivation is there and how I can use that opportunity for communication. So maybe that's controlling access. So during snack, the lid is on the box of snacks. Or maybe during snack, it's inadequate portion. So yes, you can have a goldfish, but you get one goldfish. Or we're doing a puzzle and you love this puzzle. So I'm going to give you one of the pieces and not all of them. Playful obstruction. So a lot of our kids with autism really love gross motor movement. I co-treat with occupational therapists as well. And a lot of times the communication opportunities we've been able to build in are related to swings, scooters, going down the slide, going out on the playground. Again, things we have access to here as a large institution, which I'm so grateful for, but I know that's not always the case. Making choices between activities. So maybe there's some things we really need to get done, but you get to decide kind of what it is that we do. I think the biggest thing that we need to focus on when we teach others about communication is to follow the child's motivation. So a behavior analyst would call this kind of incidental teaching, they would call it natural environment teaching, or you will hear people say NET. So they might say like, let's run an NET session. So let's be in the natural environment. Let's look for motivation and see, when he might be motivated to do something and follow his lead is another way to put that. And this, again, this is not as natural to everyone as it is to many of us. So this is something that I think teaching individuals to observe or identify existing, to me, that means describing even that, like, oh, you're reaching for this, you're reaching for the cup. Oh, I think you're thirsty, and modeling on the device or the pot or whatever it might be. You're thirsty. I'm thirsty. Oh, you might want to drink. And giving the child opportunities based on that reach, or that looking at the item, or that even body orientation for some of our kids. A lot of that is, again, it takes getting to know the child, but also knowing what motivation looks like, even if it's not super clear in kids. And then I've kind of swung a lot of different ways on the spectrum when it comes to how to actually teach other people to use the child's device, especially if it's one that they already have and this is a new person, or maybe it's a new device, or we just got funding for the device and it's just now coming in. How are we going to teach them to use it? And, at first I like to just teach the basics. So, like when you press the button, it will talk, kind of thing. Or when you press this button and you see this little arrow in the corner, it means it's going to go somewhere else, that kind of thing. And then programming second. So when you see that he's motivated for something that's not on the device, this is how you would program that. I kind of wait on that and try to take the programming on for just a bit so they can be comfortable. And honestly, the way I found the most or the best implementation from other individuals or other disciplines is to give a specific recommendation for a specific activity to start. So often this is not a super long activity. This is something the child is extremely motivated for and by, and it's an opportunity for the device to be present, or because I have a lot of high-tech users, but please input whatever it is, whatever system you might be using with your kids. Maybe that's just having the device, the therapist, and the child in a triangular format with the activity in the middle, and what it means to be engaged with the activity. Have the device set to the topics page that you, maybe it's bubbles, and it's just getting the therapist to get to the topics and bubbles page, and then you touch a few buttons on the page to model some language, or potentially have the child request to blow more bubbles, or again, whatever that might be for that child. But that aided language input part for our therapists, and I know I've looked back on another article, someone posted AAC for beginners. I'm sorry, I don't have that up here, but and it said, we're focused on do, or teach. We really want our kids to do something to show us that they know or understand what we're doing. And I think that that's even more so the case for our behavior analysts. And I'll talk more about that. But this aided language input part is we're going to talk more about when it comes to buy-in and how we're going to get people to buy into, I have to use this in front of the child, even if he doesn't look at the device, even if he doesn't look like he's listening, even if he doesn't seem like he's paying any attention, that I can still use the device to show him or to provide a language-rich environment using a symbol-based system or a photo-based system so that the child can learn to communicate with us someday. So how do we get buy-in? And I'm so excited for this part because, I have, again, my service delivery model has changed over the past 3 years immensely. And that I used to do a lot of individual therapy, and now I do a ton of parent training because I think that is one of the biggest and most important ways to increase AAC use for our kids. Because if parents aren't the ones that are advocating for its use, taking it everywhere, making sure that it's an integral part of the child's life, you're going to see less buy-in from other therapies as well. So my most favorite, and I don't know if this is how I'm exactly going to do this, but if I want to open an external link, Scott, would I just open hyperlink and then share screen to that specifically?
I believe so.
Okay. Can you let me know if you can see this? Did Facebook just pop up or no?
Not yet.
Okay.
You may just have to go back to your screen share and share.
Oh, hello everyone. Okay. Yeah, this should work.
Share your web browser instead.
Okay.
There you go.
Does this show?
Yep.
Yep. Okay, perfect. So this is Life with Grayson and Parker. And this is, ignore all my Facebook things here. But this is one of my, probably my most favorite parent on Facebook who has 2 children on the autism spectrum, who her oldest son has childhood apraxia of speech, and they recently got him a device, and they use, I think, a mini iPad with Proloquo on it. And Chrissy, his mom, has done an amazing job continuing to advocate for using both AAC and speech, and that they are not exclusive of one another, and that we can focus on both to provide both a language-rich environment and to help Grayson communicate things that he couldn't communicate with his speech. And I really wanted to share this post with you because I saw it a couple of days ago, I guess, and just thought it was perfect, just perfectly described what we want parents to really feel about AAC. And again, she really makes it her goal to educate others. And so I think this is really cool. Again, teaching other parents or parent tips, that working with a speech pathologist for sure, who specializes in AT or AAC is extremely important. Customizing the child's language, taking the device with you everywhere. Again, I posted this link in the resources, so when I share my slides, you can check this out more in depth. But again, Chrissy has made sure that she has his device with him at all times. Know the language better than anyone else in the world. This is so important, and something I'm always trying to teach therapists is that if you don't know it, then you cannot teach him, or her. But even getting therapists to touch the device is sometimes the hardest part because they think they might break it. I think this is getting better as our therapists, are coming from the digital age, and I think we're more used to touching technology all the time, so we're a little less scared of it. But I think still it's taking a little bit of time. Model again, how to put language together, and what people would even say about a specific activity. Make it motivating. Again, things that kids want to do or for sure don't want to do. My slide at the beginning about that restricted and repetitive or highly fixated interest, although we sometimes view that as a maybe, it is a challenge, but it's also such a strength because our kids love things so much that if it's about something they love, they're willing to do almost anything or to pay attention to whatever it is that you want to show them, to kind of be able to get access to that item. Again, she puts here, practice rolling up and down windows in the car and request. Like, that's so cool. I would never think of that. And I think she has some really good ideas here. Assuming competence, I think this is awesome. And I'm going to talk a little bit about the difference in speech and ABA regarding how they view language there in a second here. Use AAC to talk for yourself. Allow user wait time, don't overprompt. This is, I caught the first presentation that Rachel gave yesterday, and she referenced Kate and kind of this viewing hand-over-hand assistance or physical prompting is something that we want to avoid as much as possible. And I think that's a really cool thing to think about. And sometimes I think it's necessary, but I think that there's certainly, it's important to think about how do we avoid physical prompting or over prompting or just dependence in general as we teach our kids this. And then MLU plus 1 or 2, that's so cool, showing kids that they can ask for specific things or make choices between things they like. So maybe they like cars and they can say, I want to play car, but now I want to increase this and have them tell me more about the car that they want. Maybe they want the big car, maybe they want the little car, maybe they want the orange car, and they can kind of get more specific about what they're saying. And then she gives, again, this and her website. But again, that's all in my resources too. So let me get back here and get to my PowerPoint again. Okay. Again, education. So this should happen on all levels. Again, remember who the child will be spending time with. So as you think about who do I need to be educating when it comes to your kids who receive applied behavior analysis intervention, it's twofold, because we need buy-in from our supervisors who are master's level trained, which means that we need to have discussions about why language input is important and how we can be doing this throughout the child's day. And again, kids in ABA have programs. They call them programs usually. So they might have 10 programs that are expressive identification, or they might have an expressive identification program and a receptive identification program. So what I do is I recommend a program that's 10 minutes in the classroom with a highly motivating activity with a device. And that what we're taking data on is the number of times the child looks at the device, or the number of times the child looks at the therapist or touches the device or spontaneously uses the device in some way. Again, it feels funny because it's like, well, why should I make a program for that? But that's a way to build time into the therapist or the person who's working with the child directly into their day to make time for this. Because if not, there's a ton of other things that they're working on, potty training, feed. I mean, there's tons of stuff. And although communication is, for most of us, our biggest focus and really the main thing for us, that's not always the case in a comprehensive early intervention program. So it's important to make sure that they built in time for the therapist to work on those natural opportunities with the child throughout the day. Again, the way I've seen buy-in the most with our individuals downstairs is through success. So seeing kids spontaneously use their devices to say things that they would have never guessed that they could do. And again, I know the output is not what we want to be as our only measure of success, or but it isn't always. It can be, again, attention to the device. It can be sitting in the same space. There's a lot of things that we want to have happen. But I will say that, you know, I called one of the therapists that I work with last night, and I said, please tell me what it is that got you to buy in, because she's one of my biggest advocates. She advocates so strongly for AAC in early intervention now. And she said, I saw him use it, and I wouldn't have guessed that he could do that. And so I think her, and she now models and uses aided language input and provides that all the time, because she knows that he's paying attention even if he doesn't look like it. And I think that's really important for people to come to terms with. And then speech versus language. So honestly, the way that I've gotten the biggest buy-in just to be involved with behavior analysts in general is that they want to know information from me about speech. So they're not so concerned about what I knew about AAC to start. What they were concerned about was how to shape speech and how to help kids talk. And helping kids talk is absolutely extremely important to me, but having kids have functional communication is even more so to me. And so I was able to get my foot in the door with helping with things like, how does speech develop? What are sounds that are appropriate? What might an approximation be for 2 or 3 syllable word? What kind of target should I be focusing on now? How can I get him to imitate me? Those are the things that we started with. And then as we discussed speech and what that means, and how that's different, how speech production is different from language, people really started to come around to the idea that there was more to this and it wasn't all about speech production. And so I think if you are a good team player and you can answer some questions about speech, you might have a lot more luck on the language or AAC side too. Okay. I'm going to try to get the rest of this done in about 5 minutes here, and I know that's going to be kind of tough, but I do want to leave some time for questions, and I'm sure that many people, that hopefully we have some feedback here about what you want to talk about. So what if I don't have time or resources to work with other disciplines? And I know that it's hard because not everyone works in a center where there's multiple disciplines, or maybe your child comes to you, but you work at an outpatient clinic, and so it would require outside time for you to be able to meet with another therapist or to talk, even because again, email of course is not ideal necessarily when it comes to talking about device and programming and how to use it. But again, having parents on board and making sure that they understand what you're doing and what's important for the child to be doing related to the device. Again, if you can meet with a provider outside of therapy time, I would highly recommend it. But again, I know that's not always possible. And then potentially consider like doing some type of video modeling for therapists, and that have parents or you take a video of you using the child's system, or what aided language input looks like. How do we talk about an activity within the context of a motivating activity? And how do I build in some requests, but I'm also using comments and questions and things that make it more language rich and don't keep it just at a request level. And then again, I'm sure some of you are listening to this and think, or I disagree with behavior analysis in general, and what if I just don't want to be involved with that at all and kind of stick to what I know and what I know is right for the child. And what I would say to that is, I think the most important thing is always what is best for the child, right? And what's hard is that the way speech pathologists view language or skills, I believe, is from the top down. So we look at what's most important for the child to do day to day, year to year, their life, their quality of it. Look, what is it that's this, what's this overarching skill, and how far down do I need to go to kind of get back up there? But I'm not going to go so far down. Like I can again presume competence. I can presume that this child has the ability to catch up with me or to watch what I'm doing, and maybe not now, maybe not tomorrow, maybe not next month, but this child will pick up on what I'm doing, and they will learn this from me, again, from that kind of top down. And I would say that behavior analysis is more bottom up. So behavior analysts they do task analyses. So they think about what goes into a skill and how do I break that skill down to the point where the child is successful, and then build up that skill to the point where they're successful at the ultimate goal, which again is often always very functional, but again, it's just a different way of thinking about it. And I think if we can meet somewhere in the middle, so what's most important to you? To me, functional communication, the child being able to tell me what it is that they want and need and feel and think and all those things is absolutely paramount to me. But I recognize that, thank you, I recognize that we need to get started now. So what can I do now, and what can realistically be implemented to help move us forward? And I know that's tough, because I of course think that a lot of things need to be implemented right now. Make others feel valuable. Parents, making sure that they know that they are absolutely integral to this process. Other practitioners, so although maybe it's not your favorite thing and you've seen some ABA that you haven't been a huge fan of, I understand, and I hope that just like if you've met one child with autism, you've met one child with autism. If you've met one behavior analyst, you've met one behavior analyst. So I hope that you give behavior analysis a chance, and that it's a science. It's not a type of therapy. So if you've seen some really non-functional touch the dog or whatever it is, and then an M&M as a reinforcer, and that really bothered you, I hope that you'll keep giving it a chance, because that's not how it is. everywhere, and that's not always what it looks like. Again, this is nearly my most important bullet point, but I don't have time for it. But teaching methods for output. The person that presented before me, Amber, talked a little bit about errorless learning, and I'm happy to keep talking about that. But at what point do we kind of do that most to least prompting to teach the child quickly, or the least to most prompting, like the new article I think he came out with, and then the biggest way that I've been able to teach behavior analysts how to teach navigation and that type of thing is backward chaining. So again, I'm happy to talk more about that if you have more questions, but help them select targets that are functional. That is always my favorite thing. Again, these are things to consider that you can do kind of on your own. And then some action items, things I want you to think about as you move forward. If this is something that's interesting to you and something that you want to continue to work on as you work to collaborate with individuals who also provide services to your kids with autism. Again, they get to provide the most service, and so I hope that we're good collaborators with them, because I think we can teach them so much and make them in communication. Okay, let me try to get out of this and unscreen share so that I can answer questions. Let me see if I can look at Slack here. Scott, are you still there?
Yep.
Okay, perfect. Okay. Okay, hold on one second. Okay. Love pushing big groups to model language in ABA classrooms so they can all see my model at the same time. Yes, that's awesome. We've done some changes to circle time, which is something that our ABA early intervention does. And so they, yes, thank you for asking about backwards chaining. I'll explain that now. But real quick, yes, so circle time, we've implemented some low-tech communication boards and have been able to model kind of how we would use those, even like in a shared book reading. And so we've had a chance to kind of shape some of that circle time and make it more language rich. And it's been super, super fun to teach how to model. And that's really cool. Thanks for sharing that. Sharing research, support, and collaboration. Yes, Lil Brooksy 89. I will pull up some resources for you there. I know, I'm sorry I didn't give a whole lot today. There is a Facebook group called SPABA, or Speech Pathology and Applied Behavior Analysis, a special interest group, and I'll again share that. I'm just gonna type that here, because if they share information related to the two so frequently, and it's been one of the most amazing groups that I've been a part of on Facebook as far as speech and ABA goes. Okay, and you responded to that. Okay, perfect. Thank you, Kira Shar. Okay, backwards chaining. So backwards chaining is a lot of times basically it's starting at the end and going backwards. So we might call that reverse chaining, is actually what I've heard speech therapists call that instead in speech. So for instance, if you were trying to get a child to say cracker, you might say cur, and they say cur, and you say, yes, say cracker. So they've already practiced that last piece, and they're adding that first piece to the second piece. And so let's say I'm using, I'll give an example of like multi-chat 15, and I do on touch chat, and I'll do, let's say the child's really they really want their milk, or they're really interested in the iPad, or whatever it might be. I will model through. So I'll say, oh, iPad, okay, I want to play. And then when I get to that last page, that might be when I prompt like a point prompt, or a partial guided prompt, or something like that, where I'm like, oh, iPad, sure, yeah. The child says iPad or touches iPad. And then when they're doing that consistently and independently selecting iPad, then I'll go back a page, or I might start us at home and I'll do I want, and they say, oh, to play. And I'll do a point prompt to play, and they'll select to play. And then once they get to that page, they say, then they've already seen that page. They know what it's like, oh, there's iPad. And then they're able to kind of start combining symbols instead of from the beginning, from the end. And kids seem to, once they're independent on that last page, they're more willing to put together, or to kind of tolerate that the amount of time it takes to navigate to another page. Do you have any suggestions collaborating with ABA who continue to recommend PECS even though client is using SGD? So PECS is, a lot of behavior analysts really love PECS because PECS has been laid out in a way that's very behavior analytic. So it's laid out exactly how you should start, exactly what to, when you see this, you should move to this stage. When you see this, you should move to this stage. The creators, Bonnie and Frost, they have, there's a, I've seen that on Facebook too. It's a kind of SGDs and PECS and like the differences and why they're both important, or can both be used, or when to consider one versus another. And I will look for that as well to provide to this group. iPad. And so I think the hardest part is they know exactly how to implement PECS and they don't know exactly how to implement SGDs. Honestly, there's almost no, I can find nothing that's procedural or described in a way that behavior analysts would feel comfortable regarding how to teach speech generating devices. Because if you've listened to any of the other presentations, it's not procedural. It's providing a language rich environment, and that requires using the device. It's not a one size fits all, and that's certainly difficult from a behavior analytics standpoint to kind of go with the flow, if that makes sense, and think about that from a programming standpoint. So I guess my suggestion would be, if you can trial, do they own, if they own the speech generating device, I might talk about that this is the system that they can take from place to place. And I can't imagine that they would be taking the PECS place to place. And what I focus on the most is like, what's going to generalize? So if this child has a speech generating device at home, but we're using PECS in therapy, we're wasting our time essentially. So they're not going to be able to use this at home, and we should be using the system that they're going to have in all places. If you've just been trialing a speech generating device, but they're still trying PECS, usually the way to kind of go around that is to show that they have access to more vocabulary using a speech generating device, and the amount of vocabulary they have access to and the way that they can build language, PECS simply can't. There's not enough, like I can, with a speech generating device in just as many hits, do play, drink, go, see, want, have, need. I mean, there's so much more to that, and it requires far less flips. If you're at that point with PECS, I feel like it gets pretty cumbersome at that point, to have a binder full of all of those adjectives and all of those verbs, and so yeah, I hope that answers your question. Let me know if not. To get ABA teams using aided language, I've had teams write it as a program for the therapist. Exactly. Honestly, that if you want them to implement it, if it's a program and there's a way for them to track it using data, they will do it, and they love that. So the less loose it is, the better, which is our struggle, because I think in general, am I wanted to see where the child takes me, and I'm gonna go from there, but that's just not always how other people think. And again, they don't really have the time because of all these other programs. Their therapists are the BTs or the RBTs are focused on getting the programs done. And so if it's not a program or it's not something they're expected to do, then it's pretty difficult to convince them that it's valuable until they see it work, which again, it might not happen now, and it might not happen tomorrow, it might not happen next week, but I have so many device users now that are extremely proficient, and that it seems to have won over at least the groups that I work with here. So any other questions? It's 3:50 now, so I should, if I'm a good presenter, we'll kind of sign off now. But my email address, I will just put it right here so that if you have any questions, or you've been experiencing any difficulties, or have any kids that come up that you wish you had some more information about ABA and speech and how to work together, I would be happy to discuss. It's my favorite thing in the whole wide world. So I will talk about it at any time, because I think we have so much to teach and learn from one another that we can give our children so much more access to robust language and good learning. So thank you so much for letting me present. It's been such an honor.
Thank you so much. We appreciate you taking part of our first annual AAC in the Cloud. So,
of course, I just realized you could probably see me the whole time and I was not acting like it. So
yeah, I've been on half the time and didn't realize it either. So you have a good one.
Okay. Awesome. Thanks. Bye.
Bye.